Hi, everyone. Good morning, good afternoon, good evening. Wherever you are in the world, we're happy you're here with us.
Kiara and Kirtan are here and are going to be helping make the board, both the clinical case and the teaching points. So thank you as always, team. How's everyone doing? What's new? Does anyone have an interesting or, well, yes, every case is interesting. And would anybody be interested in discussing today? And while we wait, Kirtan was asking Steph to give us an update.
So last Wednesday, I shared a case that was currently on my inpatient team that I needed some help with. And I'll summarize the case for you and then give you some follow-up. The case was of a gentleman in his early 70s coming in with some chronic constitutional symptoms of fevers, night sweats, weight loss, who on a complete blood count done in the emergency room was found to have 260,000 white blood cells, with the differential of the cells very shifted towards the myeloid line, very big liver and spleen, both on exam and imaging, and ultimately was diagnosed with chronic myelogenous leukemia. The kind of clinical question I had for the group was beyond even the new hematologic malignancy diagnosis, and that was some surprising imaging findings that he had on a CT scan done to work up left upper quadrant, which was one of his presenting symptoms. Two different findings. In the spleen, there was an area of subcapsular fluid that radiographically looked like it was probably blood, but contained within the spleen itself. And then separate in the anterior abdominal wall, between the abdominal wall and the peritoneum, there were two kind of 4 by 5 by 3 centimeter fluid collections. They were had a wall around them, but were just very nonspecific in how they looked in the CT. So the questions that I asked the group last Wednesday is, what do we do with these fluid collections? We settled on feeling fairly comfortable calling the splenic fluid collection below the capsule a spontaneous splenic rupture, which the group in the chat found several case reports actually describing that in CML with massive splenomegaly, that the spleen just has some vascular rupture in some area and has some bleeding. That made sense. But the question became, what were these fluid collections in the abdomen? He had had no trauma to the abdominal wall. He did have a low-grade fever on admission to 100.2, but of course we debated, knowing that that sort of fever from inflammation can come from infectious and non-infectious sources. Wasn't clear to us if that could have just been from the CML itself. Long story short, as the group suggested last week, we did end up getting a fluid aspiration with the help of interventional radiology to sample that fluid. They got about 60 cc's, 60 milliliters of serosanguinous fluid out of one of the collections. It had about 3,000 total cells, with I think a fairly normal differential on those cells, and had about 160,000 red blood cells. But it wasn't frank blood, and a gram stain and a culture ended up both being normal. So in the end, what we were worried about is thinking this gentleman, before we knew his diagnosis was CML, we weren't sure if there was going to be a blast phase or a progression to acute leukemia that would require strong chemotherapy. We really wanted to rule out, for some reason, him having an abdominal wall abscess, which this was not, neither by kind of the apparent cell contents nor the cultures. Nor was it pure blood. Our other theory was, well, he had spontaneous rupture of vessels in his spleen. Could he have just also had some bleeding tendency in his abdominal wall? that didn't really fit with the content. So it ended up being a kind of nondescript fluid. I don't know exactly what happened. It makes me wonder if there had been a little bleeding that then, as it was sort of getting resolved and processed by the body, didn't have such a high red blood cell count. But what was very reassuring is it wasn't infection after all. The patient actually ended up going home soon after that procedure on hydroxyurea for cytoreduction for his very high cell counts, with a plan once he gets his insurance coverage, which unfortunately was a missing piece here, to start probably imatinib or another tyrosine kinase inhibitor. So he did well overall. His pain actually was pretty well controlled, and there was no concurrent infection. The true source of the fluid collection is still a bit of a mystery, but wasn't anything sinister like bleed or abscess, which is what we were most worried about.
Weird.
Weird. All right, where are we?
Colleen and Franco were kind enough to present cases, and but I think if and then Colleen, would you be interested? Oh, okay, awesome. Thank you. So Franco can present a case and Colleen can discuss with us. And it looks like she's the only discussant we have so far, though. Would anyone else like to join? Let's give it another minute here. Oh, awesome. Perfect. So Abdulaziz and Colleen, if you and Franco, please say hello first, and then Franco can get us started.
Hi everyone, I'm Colleen. I'm a fourth year med student in San Francisco. Nice to see you all.
Nice to see you.
Abdulaziz, do you want to say hi and introduce yourself, and then we can have Franco do so, and then begin the case.
Hi, okay. Hi everyone. My name is Abdulaziz. You can call me Aziz. I am from Somalia. I'm living now in Sudan. I am graduate from medical school. I finished my internal rotation in internal medicine.
Wonderful. Thanks for joining, Aziz.
Hi everyone, I'm Franco. I will be presenting a case today. I hope everyone enjoys it and find it very educational as well.
Looking forward to it, Franco. So maybe what we can do is, Colleen, you and I can pair up, and we'll discuss the first section Franco shares with us, and then Aziz, you can pair up with Zavin to discuss the next section, and we'll alternate like that.
Right, so I think I can start now. So for the chief concern, we have a 26-year-old male with lower back pain and lower extremity weakness.
Do you want to, maybe, should we just tackle
Yeah, okay, I will.
concern?
No, I can give you a little more of the history, I guess. So
Okay.
it is a 1 month history of intermittent lower back pain associated with weakness in the lower extremities, especially in the mornings. The patient said he cannot stand up easily in the morning and find it very difficult to climb the stairs. He denies any fever, and somehow the pain goes away with occasional NSAIDs. I think I can stop there.
Colleen, if you want to begin with some thoughts on how to approach this concern from this young guy.
Yeah, I guess when I think about lower back pain associated with lower extremity weakness, I guess the first thing that kind of comes to mind is ruling out sort of emergency situations here. Like I associate low back pain and lower extremity weakness with something like cauda equina, where you would want to rule that out right away. aside from that, I guess, thinking about, okay, so this is a 26-year-old man. What buckets did I put? I mean, so, okay, so for low back pain, I think you can have problems with like the nervous system itself. You can have things going on in kind of the vertebra or the bones. You can have muscular pain, and I think asking more questions about the quality of his back pain with regards to that is really helpful. Because he is having lower extremity weakness, I'm thinking about something that is potentially affecting the nerves, innervating his lower extremities. And this, this part about low back pain that is worse in the morning makes me think of kind of like rheumatologic or inflammatory causes of back pain, which normally present as sort of like worse in the morning and then improve with movement throughout the day, rather than something like a osteoarthritis kind of back pain that tends to be like progressive from the morning like into the afternoon and evening when people move. Kind of my first thoughts.
Yeah, I'm right with you there, Colleen. I think you've picked up a good kind of way to think about it already in terms of, what could be causing the leg weakness and what could be causing the back pain. And right, we have to assume those are overlapping at the same kind of area of inflammation or injury right now. I realized as I was sort of writing out on my paper just an anatomic approach to this, I really took the leg weakness sort of as my driving symptom to really map out at this point for leg weakness that's also coming in with back pain. When we think of the entire neuraxis that we think of from the brain all the way down through the spinal cord, through the nerve roots, through the plexus, through the neuromuscular junction to the muscle, when overlapping with back pain, I started that journey kind of at the spinal cord. And I kind of made an anatomic list of spinal cord, nerve roots, nerve plexi, and muscles. I actually left neuromuscular junction out because a painful syndrome coming with that wasn't something I had in my illness script, but you guys can sort of correct me if I'm missing some disorder that would make a neuromuscular junction problem painful. So I think really thinking anatomically along the way of what's causing the pain and the weakness with those locations is important. And then layering on some of the other symptoms that you pointed out, Colleen. So the fact that it's worse in the morning, I guess, Franco, I'm interpreting that as meaning then it gets better later in the day. Is that true? Or is it?
Some days it got better along the way in the day, and sometimes he needed NSAIDs to get it better.
Okay. So once the anatomy is there, Colleen, you're kind of laying on some of these other symptoms, including the fact that it gets better with some activity, which I think is, it is a really great thought for kind of inflammatory causes that with activity are getting better, like spondyloarthropathies, for example, is sort of the big category in a lot of rheumatologic back pain that we often think of. And then the fact that it's 1 month going on, I actually want to bounce back to you, Colleen, like the fact that this has been happening for a month and now it's sort of bad enough he's coming in. Are there kind of certain categories of causes of back pain and leg weakness at those areas that worry you more when it's been happening for weeks?
I think, I guess one of the things I would think of is kind of like a malignant process that's like growing or progressive. Certainly like an inflammatory condition at first presentation could also come on like that. I'm thinking less about like traumatic processes. It's not like this guy like bent over to pick something up and all of a sudden he had back pain and leg weakness. And then I think that's all I'll kind of say about that.
Yeah, I'm with you totally. I think my brain is kind of hearing the chronicity and worrying a lot about kind of, inflammatory sort of indolent causes of that, with sort of malignancy, infection, autoinflammation being a big part of that, particularly right without the absence of a clear trigger that we've heard of so far. So I think we'll stop there. I think, the sort of summary that we've come up with this point is thinking about what causes the legs to be weak and to have back pain on that. Where do you start your anatomic journey? And then on top of that, some of the other factors of the time course of the history and the pattern of worsening in the morning, I think will be helpful as we build more specificity of our diagnoses going forward. Back to you, Franco.
Great. So for the previous medical history, kind of a big aliquot here, he had 2 episodes of idiopathic pancreatitis 1 year prior and 5 months prior the onset of pain. He also got a enteroinvasive E. coli gastroenteritis 1 month prior the onset of pain, type 2 diabetes mellitus, and 2 random episodes of bloody diarrhea with no prior workup. He is currently with long-acting insulin plus metformin, and occasionally he used NSAIDs, diclofenac mostly. Regarding family history, his mother has type 2 diabetes also, and no social history.
Thanks, Franco. You've given us some really important information there. It seems like this 26-year-old guy is not like most 26-year-old people. He's had some issues going on in the past. So Aziz, what in his past history and the meds and stuff, does anything stand out to you as potentially relevant?
The history of bloody diarrhea, I think this related sometimes with seronegative arthritis, like inflammatory bowel disease associated back pain and ankylosing spondylitis. From the diabetic, and I don't know how linked between the diabetic and the back pain. Just sometimes diabetic has the ability to go peripheral neuropathy and motor weakness of the lower limb, but just don't have the ability to give you a back pain. And hemorrhagic pancreatitis, it's just really difficult to analyze this case and connect it between the past medical history and the real history now. Really, I don't have a good idea now. Just back to you.
Thanks, Aziz. No, I think you you bring up some really good points, and I'm kind of I'm not seeing like a very clear, single possibility either. And I would also maybe ask Franco in a minute to just round out maybe the rest of the social history, health-related behaviors, allergies, just everything up to the physical exam, especially if anything, it might give some more clarity on like the some of the causes of, the pancreatitis, for example, or something like that, as well as the, if, where this patient is, what travel and stuff we've had that may or may not kind of increase the likelihood of these episodes of bloody diarrhea actually being infectious rather than potentially tied in with something else. So do you mind, Franco, just kind of filling in the rest of the history just to streamline things?
Yeah, of course. Social history: no alcohol use, no smoking, no recent travel. The bloody diarrhea episodes were way prior of the gastroenteritis event of enteroinvasive E. coli. No allergies also. Is that okay there, or I should go to vitals?
Okay, no, that's good. I'll share just a couple of thoughts then. So, just kind of going down the line, hemorrhagic pancreatitis. I'd love to hear if in the chat or if Steph or anyone has kind of ideas about what causes of pancreatitis tend to cause hemorrhagic pancreatitis. I tend to associate it just more with, severe pancreatitis of whatever cause. But in someone who doesn't drink and presumably had evaluation for gallstones, it stands out as, that's weird. I wonder what the rest of this gentleman's kind of metabolic profile is. The third most common cause of pancreatitis in our population after alcohol and gallstones is hypertriglyceridemia. And diabetes, specifically type 2 diabetes, but any diabetes, is very much associated with hypertriglyceridemia, including severe hypertriglyceridemia. There was an endocrinologist that I worked with once that, his whole thing is that diabetes isn't a sugar disorder. It's actually a lipid metabolism disorder. And sure enough, yeah, people with uncontrolled diabetes can have triglycerides in the, above 500, above 1,000, high enough to cause pancreatitis. And then actually the solution to that hypertriglyceridemia isn't necessarily like fibrates and statins, it's controlling the underlying diabetes, and things improve. So that's one possible kind of connection. The other way that the diabetes could be related to the present presentation is, epidural abscess is on the differential diagnosis, and an otherwise completely healthy 26-year-old man who doesn't inject drugs getting an epidural abscess would be, let's say, a lot more unusual if he wasn't diabetic.
A lot more unusual if he wasn't diabetic.
Okay, that's confusing. Basically, I think we often underappreciate just to what extent uncontrolled diabetes does affect your immune system. That glucose toxic, that the high glucoses are directly sort of toxic to the neutrophil's ability to phagocytose and use their granules to kill bacteria. So people with uncontrolled diabetes get pyogenic infections, cellulitis, abscesses at a much, much higher clip than people without the same risk factors. So that's just good to note. And then moving on to these episodes of sort of dysentery, apparently. So I guess we know that the more recent one was infectious. We'll trust that was kind of confirmed to be caused by Shiga toxin producing E. coli. And the way that ties into the weakness is that Guillain-Barré syndrome about half the time follows either colitic or urogenital infections. It doesn't have to, but the time course actually fits well too. That being said, I actually don't associate Guillain-Barré with back pain either. A non-trivial minority of patients with Guillain-Barré will have sensory symptoms, but those are usually more, pain, tingling, numbness of the peripheral nerves, of the extremities, length dependent sort of, rather than pain, at the back where the weakness localizes to potentially. So that's not like a perfect kind of narrative either. On the other hand, these other episodes of bloody diarrhea, if they were otherwise unexplained, as I think, Aziz, you were alluding to, or maybe it was the earlier discussion, but that could actually be part of ankylosing spondylitis. So a lot of people with ankylosing spondylitis have inflammatory bowel disease as part of that syndrome. And in fact, if you were to do colonoscopies on every patient with ankylosing spondylitis and do random biopsies, even a majority of patients could have some inflammatory changes. So this could be ankylosing spondylitis with involved, intestinal inflammation, or this could be, Crohn's disease with now presenting with spondyloarthritis and, musculoskeletal extraintestinal manifestations. Although there again, back pain, stiffness, response to NSAIDs, all very typical with ankylosing spondylitis. But the weakness, I'm having a little more trouble explaining, because that really sounds like there's actual nerve root, cord, cauda, compression that I don't necessarily think of with just spondyloarthritis. So where should we go from here? I think the physical exam should be, really helpful to both look at, the vital signs, kind of physical findings of systemic inflammation, any dermatologic or mucosal manifestations that could give a hint at a chronic systemic inflammatory disorder, taking a close look at the joints, And then of course, the back exam, any tenderness there, as well as of course the neurologic exam, making sure to look for upper versus lower motor neuron signs, what the reflexes are doing, if there's spasticity, clonus or hyporeflexia, if there's any fasciculations or atrophy that would, suggest a lower motor neuron peripheral nerve issue, as well as more clearly defining both any sensory and motor deficits to objectively kind of confirm weakness rather than potentially a subjective, weakness that can sometimes just be experienced because pain limits your ability to exert yourself.
I like where this is going. So for the vitals, temperature was on 37 Celsius, heart rate on 86, blood pressure of 120/80, respiratory rate of 19, SpO2 of 98 on room 8. For physical examination, there was some kind of a mild pallor regarding HENT, the eyes. There were present redness and irritation of both sclera. The nose looked like a rhinophyma. There were no lymph nodes in the cervical area. Cardiovascular was within normal parameters, pulmonary as well. Abdominal exam, no tenderness, no guarding, no rebound, no masses, no organomegaly. Regarding a specific rheumatology exam of the back, there was a positive Shover test, no tenderness in the lower back, no nodules or deformity in the peripheral joints. Regarding the neuro exams, the reflexes were conserved, no sensitive loss in any extremity. There was some relative weakness in the lower extremities, no motor dysfunction, and everything was normal. Anything else was normal in the neuro exam. Regarding the skin, there were inflammatory papule and pustules in the back of the head and nose. Also erythema in checks and in the nose.
Two quick questions, Franco, before Colleen and I jump in. You used the description of the name of the back test, but will you describe what you did with the patient just to teach the group kind of what the test is and what the result was?
Okay, so the test of the Shover test consists on pointing, like putting some point in the back of the spine to test if there is some shortening or some length when the patient gets his hands on the below to their feet. So you measure that, and if there is a difference of, I believe it was 5 centimeters or more, it's a positive one.
And then I'm sorry if I missed it. Other than you mentioned something about the internal nose exam. Other than the nose being kind of enlarged and red, what was that?
No, there wasn't anything about that. Only the rhinophyma features of the nose.
Okay. And then the papules and pustules were on top of the nose and on the back?
Yep.
Okay. Thank you.
There was irritation of the sclera, or there was not?
There was.
There was. Okay.
Mm-hmm.
There was.
Okay, Colleen, very interesting exam. A lot to think about. What are your thoughts?
Sorry, can I have just a second? My audio kind of was cutting in and out as he was describing this. I'm not sure that I kind of have all the findings yet.
No problem.
I'm not sure that I know what rhinophyma is. I've never heard of that finding before. Could you describe what that is to me?
Yeah, Franco, do you want to describe what you saw on his nose, or about his nose, I should say?
Yeah, well, the nose was pretty with a erythema, pretty enlarged, and with some over pustules and papules over the nose. It was kind of a big nose with erythema, and it's like it had increased the size of it.
Okay, sorry. Thanks for your patience. Okay, so looking at his physical exam, unremarkable vital signs. I think his HEENT exam, for like the pallor, that kind of makes sense with this patient having like episodes of bloody diarrhea. I'm definitely concerned about anemia in this patient. For the sclera, I think it, for several of the autoimmune conditions that we've been talking about, like Crohn's or ankylosing spondylitis, you can have kind of eye manifestations of both of those conditions. So that kind of fits with what we've been thinking about, kind of down the autoimmune route. In terms of his neuro exam, so I guess, so no tenderness. So, one of the things we were talking about is like an epidural abscess or some sort of infection in the spine. And the fact that there's no tenderness kind of lowers that a little bit on my list. And then in terms of kind of locating whether this is upper or lower motor neurons, kind of non-specific here. The reflexes is not hyporeflexic or hyperreflexic. And I don't know, do we have any, like, in terms of muscle tone?
The muscle tone was normal.
Normal muscle tone. Okay. And then the thing that's kind of tripping me up here is it is I definitely am still thinking of like autoinflammatory diseases. I'm not totally sure what to make of these inflammatory papules and pustules on the nose and back. I've definitely seen dermatologic findings associated with Crohn's disease, like things like what is the name for it? Like the nodules that you can get associated with that. I'm sorry, I can't remember the name. But this kind of sounds like something different from that. And I'm not sure that I have kind of much of a framework for the dermatologic findings that this patient's having on his nose. And yeah, the nose is something that I'm a little confused about.
Yeah, there's a lot of findings here, Colleen. So I think in a way we're lucky because there's certainly inflammation elsewhere besides the skin and the nose, right? And so maybe we can refine our differential diagnosis thinking broadly of inflammatory conditions that are affecting this gentleman's back, probably his bowels and intestine, his eye, as well as his skin. So I think we're really now seeing beyond the back involvement, beyond the GI involvement, some involvement also with the eye and the cutaneous system as well, which should really make us sort of zoom out and think about what systemic conditions could be doing that. I think you really nicely connected, Colleen, some of the discussion we've had so far about a spondyloarthritis with associated inflammatory bowel disease still could fit really well for this situation. And particularly some of the skin findings that we can see with IBD. I don't know if the term you were thinking about.
Erythema. For some reason, I was just totally blanking.
What would you say?
Erythema nodosum.
Exactly. Yep. And then with inflammatory bowel disease too, you can get pustular skin lesions in the form of pyoderma gangrenosum as well. So I think, thinking about the overlap of that with skin is a pretty strong connection in the kind of IBD spondyloarthritis category. I think in the kind of autoimmune category also, anytime we talk about multiple organ systems being inflamed, it's important to think about vasculitides as that. Now, in this case, the predominant back pain to me I'm having a little trouble sort of tying that in directly with one of the primary vasculitis syndromes. Perhaps could be a bit easier if he had kind of bad abdominal pain as the main finding, but that's something we might have to keep on our radar in that general category. And then, I think recognizing an infectious category that could also cause inflammatory back pain, inflammatory GI symptoms, perhaps some skin and eye changes. Chronic infections like tuberculosis and histoplasmosis come up as well. So I think there's quite a bit to go forward on, but I think where we are right now is knowing whatever, again, is driving his back pain, which is what he's the most worried about. Looks like it probably is a multi-system inflammatory syndrome with a very strong signature in the GI tract, as well as sort of the eye and the skin as well.
I have a theory before we see the MCV. Were you done?
Yeah.
Just real quick, in trying to like put together the actual weakness, right? Which we said we couldn't fully explain. This guy has 2 reasons to have vitamin B12 deficiency. One is that he takes metformin. I don't know what dose and for how long, but there is a dose and sort of duration dependent malabsorptive B12 deficiency associated with metformin use that a lot of people get. And then the other is that the intestinal inflammation that happens in some of these related disorders, Crohn's, ankylosing spondylitis, Behçet's, all tend to sort of center around the terminal ileum. And the reason is that the terminal ileum is an immune organ. It has these aggregates of lymphoid follicles, right? Those Peyer's patches. So oftentimes when people with ankylosing spondylitis have intestinal inflammation, it's ileitis. So that is something that could potentially explain the weakness, not through a directly linked mechanism to the back pain, but still with sort of the entirety of the case.
Let's hear some more, Franco.
Great. I'm loving this. So the CBC, the hemoglobin was on 12.5, MCV of 90, MCH of 29. Leukocytes were on 10,064. The eosinophils were a little high, 638, no lymphopenia. The platelets were also kind of high with 500,000, sorry. The metabolic panel of creatinine, BUN, and electrolytes were within normal limits. The iron studies had a low iron of 31.5, ferritin of 28.2, transferrin of 326. The erythrocyte sedimentation rate was high on 50. The C-reactive protein was on 20. The HB1AC was on 8. Liver function tests were within normal values. The albumin was also normal, proteins normal, no increase in bilirubins. B12 and folic acid were within normal limits, HIV negative, VDR negative, hepatitis negative.
Oh, it's our turn.
Yeah.
Oh, okay. Aziz, what do you think? I feel like this case just is getting more and more interesting and complicated.
Yeah, I see that the total was normal. Just I had a question though. The patient why have high eosinophilia? That's very interested and I have big question. Is the patient have some parasite infection, malignancy that causes eosinophilia, some type of allergy? Just I think eosinophilia maybe some infection we missed it before. Why the patient have high platelet 5,000, maybe due to iron deficiency can cause high platelet. Sometimes the inflammatory process can give you high platelet. So high platelet maybe due to iron deficiency or due to inflammatory process. The other question is there's still the patient have high SR. It indicated this patient have going infection, going inflammation. I don't know where is the source of this process. The B12 and that's normal. Yeah. So still the case. I don't know where are going now. The inferiors make me a very difficult case to come now. It's back to you now.
I agree. Is by the way, everybody, that was our own Alec Rezaig who just entered our room. We all share an office here at Bentab. He's a friend of the clinical problem solvers that many would know. So yeah, Aziz, I'm similarly not totally sure what to make of these labs. I don't think they move the needle that much. You're absolutely right. And by the way, Robbie just posted a great schema for thrombocytosis on Twitter. It's sort of pretty easily explained by this inflammatory milieu plus minus the iron deficiency. The eosinophilia, I've seen on the list of causes Crohn's disease and ankylosing spondylitis. I've never seen it, but I think it could be possible. But I absolutely agree that we do need to potentially consider and rule out infectious causes, and specifically parasitosis that could mimic a lot of inflammatory disorders. Other than that, I won't say much more because I don't have much more to say. I just I think we probably need some serologies, some stool studies, some imaging of the back, and then probably at some point potentially a biopsy if there's a clearly involved area. But I'll hit it back to Franco to move us forward. Oh,
Great. So,
Franco, as part of your, what's his BMI? I'm just curious why this young guy has diabetes without a family history.
well, his BMI is over 30 of BMI.
Okay, so he is a heavy guy. Okay, thank you.
Yeah. So, giving a little more information, we got tested him for ova parasites direct observation 3 times, like in a serial way. It was negative all the times. We have also studied for BK, like tuberculosis direct observation, feces, urine, sputum, all came back negative. We end up doing an MRI of the sacroiliacs that show bilateral sacroiliac joints inflammation consistent with ankylosing spondylitis. We also did a colonoscopy that showed patchy chronic inflammatory process in all the colon. The fecal calprotectin was over 1,000. Obviously, he had a negative ANA, negative ANCA, or all negative rheumatology, serology workup. And I think I can give the final diagnosis now. It was ankylosing spondylitis plus Crohn's disease spectrum, and because of the papulopustular skin disorder, he's currently with the diagnosis of a spectrum of Suffolk syndrome related to the IBD and the seronegative spondylitis.
Wow, interesting.
Wow, very cool. Maybe Aziz and then Colleen, do you guys want to share a reflection? And then maybe Franco, you could say more about kind of Suffolk syndrome, what those letters stand for, and how he met criteria for that. But Aziz, what do you think looking back?
Yeah, it's going with the case because this young patient have chronic back pain, start with the early morning and relief at the evening. It means this back pain is an inflammatory process, and when you see this in the rheumatology, I think about seronegative arthritis firstly when you have like this presentation. About the bloody diarrhea going 2 times with unknown diagnosis, conflict with inflammatory bowel disease, seronegative arthritis. So I go with the real diagnosis. Very interesting case and nice presented case.
Thank you, Aziz. Any reflections, Colleen?
Yeah, I guess I'm not sure that I was aware of like the degree of connection between different like autoimmune diseases that we've traditionally think of as causing joint pain and kind of with IBD symptoms. And I think that's definitely something I'm gonna read a little bit more about after we get off this meeting.
Absolutely. Yeah, it's yeah, the amount of overlap is really interesting. I don't know if you want to make any comments about some of your recent.
Yeah, I'm just further humbled at how how limited on our understanding of this kind of family of disorders is, and how much overlap there is between, I think all of us in med school learned these things as like definitive diagnoses, right? Like Crohn's syndrome, like crypt abscesses, skip lesions, and like the pathology was described in so much detail that there was like, it seemed like that there's no equivocation about what Crohn's syndrome is, right? And then you learn that Crohn's syndrome can be associated with sacroiliitis, right? And eye inflammation. And then you learn that ankylosing spondylitis, which again, initially you learn as like inflammation of the lower spine, right? And the sacroiliac joints and stiffening, it has intestinal inflammation. And that if you biopsy that intestinal inflammation, it has, crypt abscesses and acute and chronic inflammation and all these things. And then the causes of these disorders, like we really don't know, right? There's an HLA sort of genotypic predisposition, but the penetrance clearly is very low, and there's obviously so many other modifying and environmental causes. And so I think in the next 10, 15 years, like we're going to learn a lot about a lot of immunology and rheumatology that hopefully will help us kind of better define, clinical phenotypes and entities, and specifically with respect to how to best treat them, right? Because like the frustrating thing is that for some of these related disorders, like the treatment algorithms are like slightly different. So depending on what you call it, when it's like an in-between case like this, depending on what you call it, like how you treat it might be different. So that's why it's important to try to name something, right? To be more confident in how you treat it. And yet our ability to clearly define and name individual cases like this is very limited and wishy-washy. And it's really, it's a challenge. So that's, as one of my interns recently said, he said, I've learned a lot, but mostly that I know nothing. And that's how I feel 10 years out.
Franco, will you just teach us a little bit about Suffolk syndrome before we turn it over to Chiara for some other summary?
Yeah, of course. So Suffolk syndrome, as I think Kirtan already put right the meaning, sign of it is acne, pustulosis, hyperostosis osteitis syndrome. It can also be related to seronegative spondylitis. It's on the spectrum of the. I always think about ankylosing spondylitis and IVD like a whole syndrome. So Suffolk syndrome is definitely something that can englobe like the skeletal, like the IVD and the skin features. It's HLV27 related also. So it's one more disease for that HLA. It's kind of a really wide spectrum of disease there. And I can give you also a little of the follow-up of this patient. He was started with anti-TNF alpha, but because of permanent high fecal calciprotein, we are already considering that there is a failure to the therapy. So we are considering to start ustekinumab, it's like another anti-interleukin antibody. So it's kind of we are standing there regarding the ankylosing spondylitis. The MRI, the follow-up MRI was really good. There was some improvement of the sacroiliac joints. So we are kind of struggling between the IVD and the skin disorder for right now.
Thank you, Franco. Great teaching about that condition and how he fit the illness script for it. Chiara, do you want to take us?
Seven and Steph, sorry to interrupt.
Please,
Do you mind
please.
if I share just one thing?
Please do.
Yes, so regarding this Sapetro syndrome, I wanted to tell you that just few days back when I was reading Kushal's tutorial, our dear friend, then while Googling and searching, I came across another thing. So there is one autoinflammatory disorders along the lines of familial Mediterranean fever known as PAPA syndrome. It stands for pyoderma gangrenosum, pyogenic arthritis, cystic acne syndrome. So if you kind of zoom back and realize, then this is very similar to that. And actually PAPA syndrome and SAPHO syndrome are very similar because, as Franco mentioned, they are along the lines of HLA-B27 disease. Because if you see pyoderma gangrenosum, it is classic for ulcerative colitis. Then we have pyogenic arthritis, which is also common in IBD. And then finally, you have got acne, which was there in our case because of folliculitis and all those things. So I was just amazed by how much we can, learn from Twitter, our colleagues from CP Solver's team, Kushal, Travis, everything. So kudos to them and thanks for amazing case, Franco. Sorry to interrupt, Steph Seven, and now Kiara, maybe you can take us home.
Great reflections. Thanks, Kirtan.
I have learned so much today. Thank you, Franco, Steph, Sabin, Kirtan, and all the amazing discussion from Colleen and Asius. I love today's case. And just some brief teaching points. We at first, Steph identified the driving symptoms. In this case, lower limb extremity weakness. So she, as our amazing teacher Aaron told us, we can divide it into our neural pathway, starting with the brain, spinal cord, nerve roots, neuromuscular junctions, and muscle. So we can find some diagnosis following this pathway. Then we learned that this young adult patient, had pancreatitis. And number one case of pancreatitis is alcohol, followed by gallstones, and like in the third case, hypertriglyceridemia. With hypertriglyceridemia, I'm sorry for my English. And in this case, we had that this patient also had diabetes. So Sabin told us that if this was the case, the management for hypertriglyceridemia can be just control the glycemia and the diabetes status of the patient. Then we have to identify who is the patient, because about this we can learn more about this patient and approach better the diagnosis. So this was a patient with diabetes, which predisposes to severe infections, especially if this is uncontrolled. Then we know that this patient had E. coli gastroenteritis, which can trigger Guillain-Barré syndrome, which may cause some of these symptoms. And this patient also had bloody diarrhea. So then we were told that ankylosing spondylitis can be manifest. It's one of the most common extra-articular manifestations. So this can be causing this bloody diarrhea. Then we identified that this patient was like overall inflamed. So when we have multi-organ inflammation, we can think about some vasculitis or some infections like TB and histo. Then Sabin told us again that this patient can be having vitamin 12 deficiency because of two things. First, this patient was taking metformin. Metformin can cause B12 deficiency, also dependent with the doses. But most likely that this patient could have had B12 deficiency was because this patient had a terminal ileum compromise due to the severe inflammation, and most of these arthropathies and inflammation diseases can compromise GI like this patient and cause B12 deficiency. Also, we had that this patient had eosinophilia, and when we have eosinophilia, we have to rule out parasites, fungi infections, cancer, and some allergies, like most common things. Finally, this patient was diagnosed with Suffolk. I once heard about that, but I have never seen a case with that. Now I have learned a lot. Thank you so much.
Thank you, Kiara. Thank you, Kirtan, Colleen, Aziz, Franco. Amazing case. Thanks everyone for joining, and have a wonderful Rest of your day.
Bye, everyone.
Bye.